starting with the national quality registers that are driven by care, we could complement them with patient-driven quality registers, which is the idea by Sara. And then to return to what we have discussed a lot here about translation and research, you will recognize this one. And it's the first step is what works. You learn what works. And the next step is for whom clinical trials you find what circumstances this works. And then finally how to implement. And of course these are the development over time, but also it's my own development, because I started more than 30 years ago as a clinical immunologist, snatching pieces of joint tissue with an arthroscope from patients with rheumatoid arthritis or different diseases. And then I started registers and following drug effects and drug use, drug safety, etc. And still, at the same time, I had these two jobs. I tried to cure and improve my own patients while being a researcher. And finally, this all came together because the difference between the two translations first is to increase knowledge, but the third translation increases health. So this is where my two jobs actually joined here at the MNC. And what we want to do is to join the patient's process in a similar way. What works? So Sara could see what works in her time graphs, and she could see that it works for her. And if you have, as you say, a group that you can compare with, you can actually understand, and then how to implement to really change your communication. And now you are, in a way, independent of your neurologist. And it's as you say, when you come to see your doctor, he asks you what medication do you take, instead of you take your prescribed medication and how. So the idea here is really to give tools to patients that are on like apps or on the web or anywhere, and you can have tools also that we have today, many web applications for care, and then to combine all these e-services that build on evidence, that works via integration, and that are spread by users, primarily patients, but also we see spread among rheumatologists of what we do, and we would like.
I have several hobbies, singing in choir, traveling, but most of all I like the gardening, and the garden is my pride and joy. My disease started 25 years ago with pain in the hand and the feet. I tried to ignore it because I'm a doctor myself, but eventually I had to go to college that gave me the diagnosis rheumatism. My disease has been quite severe, so I have had the strongest drugs from the beginning. It was a new life that began. Unfortunately, it didn't last. It has been ups and downs over the years, but still it's much better after the new biological medicines. They are more effective, but still I have to change between drugs, and now I'm on my fourth biological drug. Nowadays I work together with my doctor at a computer for ever-changing the treatment. I can check my chronic disease at home in between visits. Before I go to see my doctor, I measure my own health. It's easy, I just click on the screen and enter how I feel now.
More and more doctors use national measures from the registry. Today, 25,000 visits per year are reported directly from the clinic to the quality register in rheumatology. When Karin visits me at the clinic, I access the information that she has entered at home. The quality register uses nationally agreed outcome measures. I can also compare my results with other clinics and also with the best in Sweden. I have invited Karin to use these measures, and she gives me information on how she's doing and the effects of the side effects of the medication.
The internet support system enables me to contribute the management of my own disease. I can monitor the effects of drugs, how they help me, and if they fail. I can better understand my doctor's reasoning when we decide on my medication and how I should take it to get the best result. Now I'm doing fairly well, but we can see together when the disease becomes more active and I need a new drug.
The new drugs are so expensive that there are always questions about the rising costs. I feel confident that the drugs are used in the best way, since I can measure the effects all the time in every patient and at every visit.
Now I have a system to help me take control of the situation. I can use it to compare how it is now and how it has been before. The other day I told my husband I've never been as bad in my disease, but he didn't agree. And we looked together on the data at the internet and realized that I've been worse before. This helps me get through bad periods by myself, since I know I managed it before. The future is bright. Here in the spring the garden is wonderful and I can work in it. We are soon leaving for a 3-month trip through Europe, and that is a dream of our life. And that hasn't been possible before the new medication.
Another web page where we have the health stores. This is so far the only video in English, but there are other patient stories in Swedish. And this illustrates how we very much concretely in practice improve health in every meeting. And the idea here is that we have a number of different modules that are supported. A number of different IT modules that support different things in the care of patients. And CARE is the system where the patient enters their own results. And PEP is something that is being developed by Sofia and Staffan there, where the patient can both generate the lab referral, go and take the test and see the results of the laboratory testing without even contacting CARE. They have this incontinence from CARE. And we have a lifestyle portal that supports this, and PO is personal observations, that's what Sara illustrated, and etc. So we have a number of different IT supports that we will move into more and more apps, of course, the mobile platforms as well. And the idea is to reach these through a patient portal, as we in CARE already have the electronic health record or the quality register portal. And the patients, if we could start the process here in CARE by, for instance, task shifting. If the patient is in remission, have no side effects for the treatment, they can go and take their own lab tests, and they could use the lifestyle portal. And then, of course, they will obtain also secondary prevention. So that will be the patient's way to sort of take over and go from ideas to health. And also the patient could see things in the CARE registration, and we could also measure this in according to the concept of Michael Porter, what do we get for our money, value-based healthcare. And the patient could also perform experiments on themselves, not only by time series diagrams, like that showed you, but also multiple interventions and use of statistical software that is called design of experiments. So in this way, we have a number of roads from ideas and needs to health. And our concepts that we work with, constantly strive with in our visionary ways, from patient participation, have many wishes for, to co-production of results. That's what Sara showed, that she could improve her health by herself. And this is really the greatest untapped resource in healthcare today. We're all fighting with budgets and we're not having enough educated professionals, etc. And we move from better care to better health, to actually measure health as the final outcome all the time. And we try to create an environment for individual ideas into integrated solutions, to have an IT platform that would be like an iPhone where you could develop. There are many patients that are engineers in chemistry, but also in computer science, and they can start designing their own apps for different purposes and share them. And we want to also use the new knowledge from the research to instant effects. Since we have a system like this where you could deliver knowledge straight into the meeting between the patient and the provider, or into the meeting between the patient and the knowledge in the information systems. And we were invited to one of these funders that asked Innova last Friday for one of our ideas that we had an application for, and it's about taking all the knowledge of the data we have in our biobanks. We already have this data on every patient, but we use these data just for publications and not to use the biomarkers, genetics, etc. for care, to support care. So this is what we want to achieve in that project. And we want to change care as a society and foster care as a growth sector. So we try to think out of the box, and this is endemic at the MMC. And I talked to one of the other PhD students the other day, and she said, sometimes I don't even know where the box is. But really, you do need to control the box, and then you may even sing out of the box. The next one. And this is what we want with this meeting, to meet somebody new and to discuss things together with you. Thank you.